Symptoms differences between abdominal hernia versus appendicitis. Abdominal hernia, are you talking about an intra-abdominal hernia? Because usually when people are talking about the word abdominal and with hernia, they're talking about a hernia within the abdomen, which is a situation where a loop of bowel gets caught inside of other loops of bowel or other structures inside of the abdominal cavity to the point that this loop of bowel is stuck. And it can cause pain, it can cause the inability to pass the stool through it, which would be an obstruction or small bowel obstruction, SBO they're often called. That can be life-threatening because the bowels are cut off and even you can lose, I do appreciate the hearts, that can even lose circulation to that part of the bowel and kill off that part of the bowel. Whereas appendicitis is an infection in the appendix. There are two different things. Individuals early expect to be hunched forward. Early in the process of appendicitis, you may not see a person hunched forward so much as in a later part of the process. Early in appendicitis, people will have, here, let me explain a little bit of anatomy here. Hey, let's use our friend Francis for this. Here, Francis, will you help us? So here we are with intestines that are all looped around. Now, I'm not going to take Francis apart because if I did, everything would fall out. Because Francis has, as you can see, no peritoneal covering or abdominal muscular wall to hold things in. So this is the small intestine. This is the omentum that covers it, which often can cause problems with internal hernias. You guys can keep the hearts going. You didn't have to stop. Poor Francis. So there's different nerves that go to these. Now, what's interesting is this here gets its nerve supply from way up high, whereas the large bowel that goes around like this and then comes out the pooter out the backside, it is innervated by a nerve that starts from way low. So it's as if this was all in one long strip, which it is, sort of. It is linear. It does start at the top and end at the, everybody say it. So the nerves that innervate the first third, middle third, and bottom third come off of the different ganglia in the side of the abdomen above, middle, and below. And so when you have pain that's referred to, or I shouldn't say referred to, have pain from one of these areas in the abdomen, if it's in the part of the intestines that are first in line, that the food comes through first, it's going to be felt higher in the abdomen. If it's from the area of the middle length of it, it's going to be felt as if it's in the mid-abdomen. And if it's from the colon that goes around the outside here, it's going to be felt as if it's in the lower abdomen, even though it could be, the problem could be up here. And you would feel pain from this down in the lower abdomen. Whereas if you have a problem with your appendix, you're initially going to feel it in the what we call periumbilical area, right around the belly button here. And so that's where people will feel their pain, their abdominal pain at first when they're having appendicitis. Then, as it worsens, the appendix will actually touch up against the peritoneal lining and cause a local area of inflammation, and you'll feel that pain right where the appendix is. And that's roughly 1/3 of the distance from the front bone of the hip to the belly button. When I say 1/3 of the distance, I mean if you measure that distance from, now let's get Francis again here, from this bone here up to the belly button, 1/3, the first third right here is where you feel it. Well, you can see that's really close to where the appendix is. I think they're trying to represent it right here. If it's rubbing up against the inside of the lining of the abdomen there, you're going to feel the pain right there. And that's because of the pain in the peritoneal lining, not in the appendix itself, because the pain in the appendix itself is felt in the periumbilical area there. So there's this progression. First you feel it around the belly button, then you feel it as the pain gets right there, irritates the lining of the abdomen. And that's usually hours into it. It doesn't have to be, but usually hours into it. And then you'll start to get a fever. But before that, I should back up. So first you feel just kind of nausea, actually even before the nausea, loss of appetite, or what we call anorexia, loss of appetite. So you don't have the appetite first, then there can be nausea, then this diffuse pain around the belly button, which can move or migrate to the lower right quadrant of the abdomen. Fever can come with it. You can have vomiting. There's some other things that can happen, but the classic triad is a loss of appetite, right lower quadrant pain and fever. But it goes through this pattern. It usually goes all the way to rupture within a day. So people who go to the emergency department with abdominal pain, it's been going on, and then go back, and something happens the next day, and then they go back, and something happens the third day. Usually that's not appendicitis, because most often it will present itself within the first day. That's the classic pattern. There is an argument out that there is something called chronic appendicitis, and pathologists will look at appendices, I guess that's the word for plural of appendix, and see that it looks like something had been going on for a longer period of time, but that's rare. Abdominal pain, when it presents in the emergency department, is a very difficult thing to treat. In fact, we estimate that only half of cases of abdominal pain that come to the emergency department leave with a diagnosis of what it actually was, because it can be all sorts of things. It can be appendicitis, it can be an intra-abdominal hernia, it can be a different type of hernia that has a blockage, it can be something called mesenteric adenitis, which is just simply inflammation of the mesentery here, the lining outside of the intestines. It can be an obstruction. It can be something called a volvulus. It can be diverticulitis. It can be an abscess from a diverticulitis. It can be constipation. It can be a urinary tract infection. It can be a dilated abdominal aorta, or one that ruptured. It can be loss of blood supply to the kidney or to the intestines because of a blood clot in the artery. So as you can see, abdominal pain can be so many different things, and not all of these things are something that would show up on a test when you first check. Maybe when you recheck. And so one of the things we teach people about abdominal pain is it evolves, and serial exams are the way to handle abdominal pain when it's not obvious at first. You say, you know what, it could be a lot of bad things, or it could just be gas. So given that we're not seeing evidence that you have acutely bad things going on in your abdomen right now, go home and we'll recheck you in so many hours or in one day, depending on what the situation is or how acute the pain is. Sometimes we actually will, in the emergency department, talk to patients and tell them to come back in 4 to 6 hours, and I will re-examine you at that time. It's good to have the same person do the exam, because they can, from exam to exam, detect changes. And we actually lay our hands on the patient and see how it feels. Now, I'm talking a little bit from the old days, because we didn't get CAT scans on every single person who came to the emergency department with abdominal pain when I was in emergency medicine. Okay, somebody says, oh, that's not bad, I am to walk around fine. If people can walk around, usually you can, and that's kind of a test that sometimes we'll do. Can you walk around? One of the things you'll notice in people who have peritoneal irritation, or that appendix rubbing against the peritoneal lining, is that when they take a step, it hurts because it shakes them. And sometimes we'll do this little thing during the evaluation when they're laying on the exam table. We'll hit their heel with our fist. And if the jolt of that going up through the body hurts them because such little amount of movement causes pain, that's what we call a peritoneal sign, or a sign of peritoneal irritation, and we take that very seriously. Other things that are done are rebound sign, or rebound tenderness, where you press down in the abdomen on the opposite side and let go suddenly. Now, go ahead and do that to yourself now. You push in and let go suddenly. You feel a little spring action of your abdomen coming back out, some of us more than others, and it doesn't hurt. But when somebody has peritoneal irritation and you do it on the opposite side of the abdomen from where the problem is, it'll hurt because it shakes the whole abdomen, and they feel it on the side where the pain is. So that was a good discussion of abdominal pain. I hope that I answered some of your questions. I know I didn't get to everything. I apologize. I can't answer every subject on every Periscope, but we'll keep doing. Oh, you guys are so kind. Thank you so much. And thank you so much for the hearts and for sharing with your friends. I encourage you all that haven't already to follow me on Periscope, do that. And please be sure to also subscribe to the Auburn Medical Group YouTube channel, where we put a lot of these discussions and also put a lot of things we don't put on Periscope. Okay, thank you. I got to go. Love the hearts. Thank you so much, guys. And as always, this is Dr. Vaughan telling all you guys to stay in good health.